So this is the Chronic Care Management, or CCM, Common Rejections and Denials. My name is Ellen Vera, and I'm with our Provider Outreach and Education Department. On our call today is my friend and colleague, Mary Muko, who will be watching our chat function so we can respond to questions. We also have on the call today Dr. Joelle Volhakis, one of our contractor medical directors, and she'll be providing just some very brief information here in just a moment. The slide that we have up for you now is just our disclaimer, and it just lets you know that the information is accurate as of today. However, if you've been with Medicare for any length of time, you know that Medicare rules and regulations can change. They can change often. The final determinant of coverage is going to be those Medicare rules and regulations. We are going to respond to your questions and look forward to that. Our response will be based on the facts that you're providing to us, but Medicare rules will determine any final coverage. And then CMS does prohibit recording of this presentation for profit-making purposes. So if you're recording this, if you're using screenshots, anything like that, we would ask that you discontinue that at this time. These are just some of the acronyms that we're going to be talking about today. So as we're going through those, you can refer back to this slide if you choose to. So our objectives here today are really to alert you to the more common rejections and denials on chronic care management services specifically. We want to provide information to you so that you are not receiving these denials. We want you to be paid for the services that you're providing to the patient. And then we're also going to talk about some actions that you can take if you receive a rejection or denial. So before we get into our agenda for today, I am going to turn it over to Dr. Volhakis. Dr. Volhakis, if you want to provide some information on why chronic care management services are so important.
Thank you, Ellen. I'd be happy to. I have become a fan of chronic care management services because of what it does for patients, certainly. It's a holistic, proactive way to manage patients within the context of family and community. As somebody who's an internist and a pediatrician by training, and then a palliative care physician by specialty, I can really appreciate that we are really trying to keep patients out of those environments that are so disruptive, such as emergency departments and hospitals. In addition, though, I've become a fan of chronic care management because of what it can do for physicians and their practices. It is a very satisfying way to practice once this gets up and running. It's a way for you to really use your staff well and to begin to build some of that, which I feel we've often are missing in typical clinical practice. The opportunities to really avoid bad outcomes by simply giving a little extra. I think it's also a great way for patients to feel connected to their provider in between visits. And again, with care fragmentation being such an issue and a loss of care coordination, that's wonderful. But for providers, it also feels meaningful and it feels good to keep your patients out of the hospital and see them doing well. It also feels really good to support their families. We all know instinctively that illness is a family experience, and chronic care management really honors that. It's a paradigm shift. It's more than simply a problem focused, a reactionary approach. It is proactive and it really tries to get at problems before they start. I wanted to just give voice to the fact that this presentation really was born about from questions that people have had of our team since we started this project in September. People wanted to know, listen, I want to do this well, I want to do this right, and we've been getting denials and I don't understand. And I thought to myself, if somebody is really willing to try this program and work it and do what's right for the patients, we want to support that effort as best we can. And so my friend and colleague, Ellen, has carefully and thoughtfully put something together that will hopefully allow you to be more successful when you're submitting claims for chronic care management. You and your teams, you deserve to get paid for the work that you do. Medicare has assigned value to this, what I call thought work, this brain work that many of you do without even really blinking an eye in between patients while you're running to do something else, and you deserve to be reimbursed for that, and Medicare knows that. So without further ado, I'm going to hand it back to Ellen, and I just want to thank everyone on the call for your interest and your time, and we want to make sure this is worthwhile. And please, at the end, do take the time to fill out your surveys about us. We really do pay attention to those. So with that, thank you so much, Ellen.
Thank you, Dr. Vahakas. We appreciate that. So our agenda for today is we're going to talk about how claims are processed through Medicare. And then we're going to talk about some of the different rejections and denials that we have seen, and then how to prevent those, and then how to fix those if you've received a rejection or denial. And then, of course, we want your questions. If you're seeing particular situations within your offices, let us know what those are. We will try and find answers for you. So the graphic that you have up on the slide right now is really kind of a life of a claim, and it's a kind of a simplified version, obviously, but you're providing the service and then you're submitting the claim to us. Well, one of the things that can happen is that the claim itself has an issue, or the batch that you're submitting to us with those claims has some type of an issue. So our electronic system then will reject that claim or that batch back to you. So it hasn't actually come into our system yet to process. Since it hasn't come into our system to process, that means that this won't be on a remittance notice, but it will be on that 277 or 999 report. Now, we've heard from some offices that the office itself is not actually the ones who are looking at and evaluating that 277 report. In some of your offices, you could be using a billing service, but you want to make sure that they're paying attention to that report so that they know what claims have actually made it into our system. They know what claims maybe needs to have something changed on it, etc. So the next graphic that we have is for an unprocessable claim. Again, you have provided the service, you've submitted the claim, but there's something technically wrong with that claim. This could be a transposition of numbers for your procedure code. It could be the procedure code's not in the right place. It could be a situation where your rendering provider and your billing provider don't match, etc. So what we're doing with an unprocessable claim is we are really rejecting that back to you. We can't process the claim because there's a technical problem wrong with that individual claim. This does appear on your remittance advice. So you will receive information showing you a CO denial, and that CO denial, usually it is going to be CO 16. That's going to tell you that this claim was rejected. You will have an additional reason and remarks code that will tell you that you don't have appeal rights. And then 99% of the time, you will have a third remarks code that tells you what's wrong. Procedure code is invalid, or modifier and procedure code don't match, or whatever the situation might be. Let me go back to this slide. You want to make sure that your systems are bringing in that third reason and remarks code. We get a lot of telephone calls from providers. They know it's an unprocessable claim. They know they don't have appeal rights, but because their system has not brought in that third reason and remarks code, they can't yet determine exactly what's wrong with that claim so they can fix it and resubmit it. So that's something you can check in your systems when you get back to your desks. And then the last one is a process claim. Again, you've provided the great service, you've submitted the claim, and either Medicare is paying the claim, which you'll see that on your remittance notice, and then receive payment, or there is a denial reason, and then you'll also see that on your remittance notice. For process claims that have been denied, you will have appeal rights. So you want to look at your claim submission. Again, you want to be submitting electronically. You want to be watching those reports. I noticed that Mary had put information into the chat concerning the advanced communication experience, I think, smart edits. These are edits that are going to happen before the claim actually gets into our system. And what she put into the chat was a link for an article on our website that can provide you more information. Currently, we're editing against a valid procedure code and a valid diagnosis code for your data service. On that 277 report or your remittance advice, it will define any errors that have been identified, whether it's an unprocessable, whether it didn't make it into our computer system, etc. And then you want to correct kind of whatever is going on with that, and then you can resubmit the claim into Medicare. Now let's talk about the differences between a rejection and a denial. Well, a rejection, again, as we talked about, it did not actually process. There's a technical problem with that. You can see they're missing or incorrect information. So we can't yet make a decision on whether or not we can pay the service. You can also see there are no appeal rights. You'll have at least those two reason and remarks codes, the CO16, the MA130. The MA130 simply says you don't have appeal rights. The patient is not liable at this point because, again, we have not received a correct claim. You want to fix whatever the error is and then resubmit that as a new claim. A denial, on the other hand, is that we did receive it into our computer system, but it fails to meet some type of payment criteria. It could be medical necessity, it could be a frequency issue, beneficiary eligibility issue, etc. Could be Medicare secondary payer, whatever the situation. You do have appeal rights on this. As we go through the presentation, though, one of the things we will talk about is those situations where you may not want to use your appeal right, but you want to resubmit the claim. What you'll receive on your remittance advice is that MA01, and that just lets you know that you have appeal rights on this. And then your patient liability is determined on that remittance advice. Depending on the type of denial, it could be that the patient is not responsible for payment, or it could be that the patient is responsible. So one of the rejections that we have seen for chronic care management services is that the individual provider is not on the claim. All claims for these services must contain a rendering provider. This is going to be the physician, non-physician practitioner for our Part B services that is overseeing that patient's care. They're providing general supervision to the clinical staff that are actually providing the service. You can see there it's in box 24J on the 1500 form or the electronic equivalent. So what you'll have here is, even though your physician did not see the patient in person or through a telehealth encounter, that rendering physician, that supervising physician, still needs to be on that claim. And again, that is under general supervision, where the provider does not necessarily have to be in the office, rather than direct supervision where they do. Another high denial that we saw with CCM services is that the patient is not an original Medicare patient. They do have a Medicare Advantage plan. When the patient comes into your office, you want to make sure you're having those conversations with them. You also want to be utilizing our patient portal to look for eligibility, to look for whether or not there is a Medicare Advantage plan, whether there's Medicare as secondary payer. And then you want to submit that claim to the Medicare Advantage plan as the patient does not have liability until after that MA plan actually processes that service. The next one that we have here, and this one can get a little confusing. CMS has 3 different innovations or payment models that are available for some providers, not necessarily all providers, but primary care first is about 8,000 providers total, and that includes the seriously ill population payment model. And then you have accountable care organizations. As part of all 3 of these different payment models, chronic care management is already included in with the reimbursement that providers are getting for being part of these programs. In our particular jurisdictions, Nebraska has providers who are part of primary care first. The greater Kansas City area, both Kansas and Missouri, and then Michigan has providers within primary care first. Accountable care organizations are a little more widespread, and then the seriously ill populations are really a subset of that primary care first. So if you have patients, if number one, if you're part of one of these programs, and for a patient who is attributed to you, and CMS identifies those patients for you as part of this payment model, then you would not submit chronic care management services separately. Now, if the patient is attributed to another practice under primary care first, for an example, but they're not attributed to you and you're providing CCM, then you can still submit for that. In addition to that, if you're doing principal care management, then you can also submit for that, again, if that patient is not attributed directly to your practice. If you're not sure whether or not you are part of primary care first or one of these others, you do want to be looking to your management or your executive staff because they would have entered into those contracts for these payment models with CMS. The next thing that we have then are bundled services. One of the things that Mary is going to place into the chat function is a link to our National Correct Coding Initiative, the information on the CMS website. And so chronic care management is bundled into additional things. If your provider, your rendering provider, is also doing home health supervision or hospice supervision, then you don't bill separately for the chronic care management. Now, that doesn't mean that a patient who is receiving home health and either the home health agency medical director or another provider in the community is providing that supervision, it doesn't mean that you can't provide chronic care management services. What this means is that you can't, one provider can't bill for both home health supervision or hospice supervision and chronic care management. The next one listed there is end-stage renal disease. These are those monthly assessment services. There are several procedure codes that go along with that. And they're really kind of assessing the patient and then assessing the way that the patient is receiving the dialysis, whether it's assessing the bruits or whatever it is that they're doing. The next one then is you cannot do both complex chronic care management and a prolonged E&M service within the same month. So what that means then is if you have prolonged services that you're doing with either an inpatient encounter or a hospital encounter, and you're providing complex chronic care management services, which is for a patient who's really receiving more time, number one. And then as part of complex chronic care management, the patient is also receiving moderate or high complexity medical decision making. Now you'll notice that this says complex CCM. So if you're doing just chronic care management or principal care management, and you're doing a face-to-face or telehealth during that same month, you can submit those prolonged evaluation and management codes. And then there are some other services that are identified as part of chronic care management, and these are in your CPT. All of that, however, will be part of those National Correct Coding Initiative procedure to procedure edits. The next one that we have is that the modifier that was submitted with the CCM service is not valid. So this goes into a couple of different things. If you're doing an evaluation and management service and you're billing for CCM on the same date, which can certainly happen, chronic care management services are a monthly service. We advise that you bill at the end of the month so that you can capture all the time and activities that you have provided. If you have an E&M service on the same day, you don't need a modifier. It's not part of the NCCI procedure to procedure edits. So you wouldn't need to submit a modifier in that situation. If you believe that there is a modifier that would apply, you just want to make sure that that's a valid modifier for that CCM service itself. The next rejection that we have is for railroad beneficiaries. Those claims do not come to us. They actually go to Palmetto GBA, which is another Medicare administrative contractor. You'll be able to tell that the beneficiary is a railroad beneficiary by looking at their Medicare card. As you can see on the right-hand side of your screen, patients who have Medicare through railroad, it does state that at the bottom in red. Again, the patient has no liability until the railroad contractor processes it. This information you can also gather through our patient portal. The next one that we have, and these are denials, these are going to be duplicates. Now, these are the most common denials, not only for chronic care management services, but practically for everything else. They're also the most costly for both the provider community and for Medicare. When we are denying a service as a duplicate, it could mean a couple of things. Number one, we have an exact claim that we have already processed. Everything is matching up. Procedure code, data service, number of services, billing provider, everything matches up. Well, Medicare has already paid for that, therefore we're not going to pay for that again. For chronic care management services, it could also be that another provider has submitted for the same month. One of the requirements for CCM is that only one provider can bill for CCM or complex CCM within a single month. That's a conversation that you have with your patient to make sure that no one else is billing for that. That doesn't apply to principal care management. You can have additional providers who are doing principal care management for that patient. When we're looking at services were previously submitted for the same month, that's the reason why we say it is a best practice to bill at the end of the month. That way you're not you don't kind of get confused on what you've already billed and bill the same procedure code twice, or bill in each additional code it really is the best practice to wait at the end of the month. Now, if you have received some type of duplicate denial, the first thing that you want to look at is you want to go into our portal and you want to look for that previously processed service. It's going to be there. If Medicare is denying this as a duplicate, then we have already paid that service for that patient. If you're not finding something under your Medicare provider number, that's when you're going to reach out to the patient and find out whether or not there's another practitioner involved in their care who may have already submitted this. And then it's a conversation as to who really is providing the chronic care management service. When you check the portal, if we have an amount applied to deductible, this could mean that you didn't actually receive payment, but the amount approved was applied to that patient's deductible. And then depending on what situation you have found, then that will determine what you do next, whether you request an appeal or simply change and make more accurate the actual claim that you have, and then resubmit that into Medicare. The next thing that we have just talks about some of those Medicare rules. Again, it is a monthly service. Only one provider can submit during the month. And I can't stress to you enough how really you want to wait until the end of the month in order to gather all of the time, all of the activities to determine whether it's a chronic care management or complex chronic care management. Another denial that you may receive has to do with whether or not the patient had an encounter with that billing provider within the previous year. This can be done face-to-face or through telehealth. This is required. An initiating visit is required for new patients to your practice, and again, for patients who had not been seen within the previous year. Another denial that we receive are the add-on codes. Each of the different procedure codes has each additional code. So as you can see here on your screen, for an example, the 99425 cannot be billed without a 99424 during that same month. The 99425 is an each additional code representing additional time that has been submitted or has been provided to that patient. The other thing is there are two sets of procedure codes for each of the principal care, complex chronic care, and chronic care management. One is for the physicians or practitioners, and then the other procedure code is clinical staff. You only submit one or the other during that month. The practitioner codes, that is time spent only by the practitioner. For the clinical staff codes, that can be time by the clinical staff or by the physician or practitioner. Sometimes your physicians have provided services directly to that patient, even though it's not a face-to-face or telehealth encounter. You can count that time, but if they don't meet the entire time of the procedure code, you want to include that in your clinical staff time. Another issue can be where services are being billed during an inpatient stay. When you're submitting your chronic care management services, use one date. So your date of service is going to be 5/31, as you can see on your slide there. You don't want to use a range of dates. Number one, you're only using one unit of service. For your add-on codes, there could be additionals, but it's a monthly service. So submit it with one date, and that's the date at the end of the month. If your patient happens to be in the hospital on May 31st, but you have completed the chronic care management services, both the time and activities, patient is meeting all of the requirements for that, then simply move your date of service to the date when you did complete all of the time and activities that go along with that. So for an example, you completed the 30 minutes worth of time on May 20th. The patient was in the hospital on May 31st. Simply change your date of service to May 20th. That is perfectly acceptable with Medicare, and it is still accurate. Now, another denial that you can receive is on medically unlikely edits. And Mary is putting into the chat a link to where you can go and find this information. Medicare does have restrictions on some services to the specific units of service. Now, you can see here, if you look at the 99424, 426, just as examples, these are the initial time codes. So the 424, I think, is the principal care management, the initial 30 minutes of time. And then you have the 99425 procedure code, which is the each additional. And you can see there that you can have 2 units of that during a particular month. And then it goes down and gives you a listing of the additional procedure codes. Just as an example, the 99489 procedure code, which you can have actually 10 of those during a month, that is the chronic care management, each additional by clinical staff. Some of these are restricted to 2 units. And so what that basically means then is that if you provide more than that, it's just something that you don't bill for separately. It is part of what has already been provided to that patient for that particular month. And then we have denials based on the patient's date of death. And this, of course, can happen also. And again, you do the same thing. Look at your date of service and change that date of service to when all of the services were completed. Now, obviously, Medicare's not going to pay for any time or activities after the patient's death. So you want to really look at your documentation. And then once you change that date of service to when you completed the activities, then you can resubmit that to Medicare. And then we have late filing. Late filing is when you have not submitted that claim to Medicare within 1 year from the date of service. You cannot collect from the patient unless you are collecting what would have been the coinsurance amount or any unmet deductible. Medicare is really pretty strict on the late filing. About the only thing that will allow us to bypass that is if there is some type of issue from the Social Security office where the Social Security office did not give the correct information, either their eligibility date, a date that they were not eligible, etc. So again, you can collect the coinsurance amount, and if you can identify, then you can collect any unmet deductible. So what are the next actions that you take? Well, for a rejection, you have to correct the error, whatever the situation is, and then you resubmit the claim. For a denial, you have several different options. You can fix the error, whatever caused it to deny, and then you can resubmit the claim. This is faster. If Medicare has what's called a payment floor. And so if the claim comes in, there's no additional problems with it, then it can be paid to you within 14 days of the date of receipt. If we get into a clerical error reopening, that's where you're going into the transactional portal. You're making a change, whatever you need to change. This could be adding a modifier, could be removing a modifier, it could be changing the units of service, whatever the situation might be. And then you're doing that through that transactional portal. And so then that processes as a new claim. Since it processes as a new claim, then it does not use up your appeal right for that particular service. And then the last option that you have there is an appeal. And we have information available on our website, both how to deal with unprocessable claims, how to perform and what is applicable for a clerical error reopening, and then how to do an appeal. You want to do these through the portal when it's available. And what I mean by that is that there are some things that can't be done as a clerical error reopening. I don't think any of the chronic care management services fall into any of those exceptions, but you want to look at those exceptions. You also want to do your appeal through the portal. This is where you can identify the specific claim. You can provide us with information on why Medicare should not have denied it. You can upload documentation if you believe that that would be helpful for us to make a different determination. What you want to look at when you're doing an appeal is to keep in mind we've already made a decision, and our decision was to deny or to downcode, um, although that's not as common with chronic care management services, but we've already made a decision to deny. So when you're submitting that appeal to us, you want to be specific. Um, Medicare should pay this claim because it is the only chronic care management service the patient received in that month. Medicare should pay this claim because we have only submitted one of each additional procedure codes for this particular month. We provided the original service and it was billed on this claim, and then we have each additional, and it for some reason was on a different claim. You want to be that specific. You don't need to upload documentation for everything. It's only if you feel like we really need to see that documentation in order to support the fact that you believe Medicare should pay for that service. So those are the most common reasons that we have seen for chronic care management services to either be rejected or denied. So the next thing that we'll do is we will take any questions that we have received. So Mary, do we have any questions?
We do, Ellen. This question is, as a critical access hospital method 2 facility, is CCM submitted on a 1500 or UB claim form?
Okay, the chronic care management services are going to be submitted the same way that you would submit any of your other professional services. I'm not an expert on chronic care, critical access hospitals, but if you submit your E&M services, et cetera, on a 1500 form, then you would also submit your chronic care management services on that 1500 form. And for a method 2 provider, I think you do submit on the 1500.
Ellen, we have no more questions at this time.
Okay. So as Dr. Valhaka said, we really want to allow you and help you get paid for these services. These are services that you're already doing for your patients. You know, your nursing staff is taking phone calls from the patients. They're calling patients back. Your frequent flyers, again, your administrative staff probably knows who those people are. Your frontline staff knows who those people are. And so this service really, under this structure, really allows you to get paid for these services that you're probably already doing for your patient. And again, you know, we've talked about the most common reasons for denials and what to do about those. Well, went the wrong way. There we go. So what we have up on your slide for you today is a link to our survey, and then we have a QR code that you can use with your smart device in order to take a survey. And we really do encourage you to do that. We use the information that you provide back, both in our reporting, um, both in the in us looking at our presentations themselves. There is also information on that survey where you can indicate additional education that you want to see in the future. And so we look at that also in determining our education. What's on the bottom right-hand side of your screen is what your screen will look like once you leave WebEx. And I do have seen some additional questions, but that's what your screen is going to look like. Now, it's not a spam or anything else. It's only telling you that you're getting ready to leave WebEx in order to open a new window. And the new window that you will open will be the survey. And then you'll also receive a link. Can you tell that we really want you to complete the survey? You'll also receive a link to the survey in your thank you email. As also part of that thank you email for attending today, it will provide you with information on this course, and it has a certificate of achievement on there and then provides the hours. You can use that with your accrediting organizations in order to collect your continuing education units. Mary, did I see that we had additional questions?
We sure did, Ellen. The first one is this. Will you be doing a webinar on CCM denials for rural health clinics where the service is billed on a UB04 as a type of bill 71X?
We don't plan on doing that specifically. When we did the data analysis, we did not find that we were receiving or had performed, I guess you could say, a lot of denials for rural health clinics or federally qualified health centers. If you are receiving denials, you can bring that up now. You can also use that email address that's on your screen for follow-up questions, and we'll research that further.
All right. The next question, for the denials related to the patient being in the hospital during date of service, we typically change the place of service to 21, add the admission and discharge dates to the claim, and then resend the claim to Medicare. Is this appropriate? We used to change the date of service to before the admission, but then we would get denials stating there wasn't 30 days in between billed CCM CPT.
Yeah, and that can be a reason for denial also, if there's not 30 days between the services. You can certainly do that by indicating that admission and discharge date. Part of what we look at though, and it's called the CWF files or common working files, is it compares when patients are in the hospital or receiving skilled nursing facility care to other services that have been provided to that patient. If by changing that place of service code to 21 to reflect that that really is where the patient is on that date of service, if that's working for you, then that's perfectly acceptable.
All right, next question. We are also critical care hospital and rural health clinic. We are also part of an ACO, but I have never heard that we could not do or bill CCM services with ACO attributed patients. Does this apply to critical care hospital, rural health clinic also?
It applies to patients who are or providers who are part of that accountable care organization. So if you're part of that accountable care organization, and what you'll need to look at is the structure that you have and how, whether your physicians who are part of your critical access hospital or your rural health clinic, whether they are also part of that ACO And if so, then you would not want to bill separately for that.
Next question. Does resubmitting a claim on a rejected claim denied that has an appeal right with 4 options cause a duplicate claim denial?
No. If the claim did not pay to begin with, then you can fix and resubmit, even if it's not rejected, if it was an actual denial. You don't want to resubmit if Medicare paid something on that original claim, because that will generate a duplicate denial. But if our allowed amount was 0 on the first claim, and you discover you needed to change a data service, you needed to change whatever, then you can resubmit it as a new claim, and then if Medicare pays it, you receive your payment faster.
All right, one last question that we've received so far. We were receiving denials for Medicare, and when I would call on a denial, I was being told that the G0511 needed to be billed with a CG modifier, which I referenced the Medicare policy that was effective several years ago, indicating differently. But I added and then it denied, stating the CG modifier was invalid. Has there been a problem with the Medicare claims processing system?
I would like you to send that into the follow-up questions. And if you could provide us with the internal control number of a couple of examples, because my understanding is that you would need to use that CG modifier. But if you have submitted it both ways and received denials both ways, then we need to do some further research into that. Now, when you're submitting that, only submit those internal control numbers. You can include a data service with that, not your beneficiary name or your beneficiary's Medicare identifier, because that's, not information that should be sent by email. But send us the control numbers. Let us do some checking into that one.
These are some great questions, but this is all I have at this time, Ellen.
Okay. Well, we want to thank you all very much for taking the time out of your day to attend this course this afternoon. Again, please take a moment to take the survey. We also have for you just some resources, and most of these Mary had already placed in the chat. But if you're looking at your handout in an electronic format, all of these are links where you can go and find more information. So thank you very much for attending. Mary will ask one more time if there's questions.
There are no questions, Ellen.
Okay, thank you very much. This will end our presentation for today. Have a great afternoon.